All right, looks like we'll get started again. Happy New Year. Welcome to this first episode in the new year. Today is January 4th, 2023. My name is Jessie Kenzie, and I'm an account manager with Mountain Pacific Quality Health. And this is Mountain Pacific Quality Health It's Worth a Shot series. Today we'll be discussing the Montana Infection Control Mentorship Program, kind of a follow-up to an earlier presentation a few months ago. And also we have a very own peer that will be speaking on RSV in adults today. Next slide, please. As always, a special thanks to all our speakers and partners and attendees. And I would say, although today is only the 4th, 23 is shaping up to be a great year. Next slide, please. As always, feel free to add any webinar topics or clinician ideas into chat. And we do look forward to meeting every Wednesday through the year. And we do have a polling question today to kick off the year. Do you think that staff vaccination rates can be increased in your center, specifically COVID-19 vaccination rates? Give you guys just a few moments to reply to that polling question. Again, do you think that staff vaccination rates can be increased in your center? All right, it looks like the majority of folks responded yes. That's great news. All right, we can go ahead and end that poll. Looks like 68% of attendees shared they feel like they can increase those vaccination rates. Again, great news. Please reach out to us if we can provide assistance or resources to help you in your vaccination efforts. And next slide, please. We'll take a look at the weekly influenza snapshot. This was for data capture for the previous week, and we have some positive news. Seasonal influenza activity, although it remains high, it does continue to decline in most areas. And of influenza A viruses detected and subtyped, it does look like they continue to be mostly influenza A, with a very small percentage, specifically 83% were influenza A, the H3N2, and a small percentage, about 17%, were that H1N1. We are unfortunately seeing additional pediatric deaths. There was 14 additional pediatric deaths reported last week. For now, a total of 61 pediatric flu deaths reported so far this season. And CDC continues to estimate so far this season, there's been about 20 million illnesses related to flu. So just an ongoing reminder, annual flu vaccine is the best way to protect against the flu, and vaccination helps prevent infection and also serious illness. Next slide, please. And as we look at weekly COVID-19 data and a quick snapshot here, again, we are seeing some positive news on the horizon as far as our daily updates for the United States. A decline in weekly total cases reported as of that December 30th reporting period. Decline in deaths. However, there was unfortunately an increase in hospitalizations related to COVID-19. And again, unfortunate to report, the majority of those COVID-19 associated hospitalizations were pediatrics. And just a small comment here that even though we're seeing a little bit of a decline, the World Health Organization is monitoring very closely an increase in deaths in some European countries, such as France And you probably are aware, just last week, December 28th, the CDC officially announced a requirement that negative COVID-19 tests will be needed for air passengers coming from China. So again, unfortunately, we're seeing some increase in deaths and cases overseas, and the World Health Organization is watching that. So stay tuned for more as we continue to monitor this, and we definitely encourage vaccinations with the up-to-date vaccine as your best way to protect against serious illness here as well. All right, next slide, please. So without further delay, I'd like to introduce Stephanie Tesaro, and she is with the Montana Infection Control Mentorship Program through the Montana Public Health Institute and Department of Public Health and Human Services. And she is going to be giving us an update on the program. Thank you, Stephanie.
Yeah, thanks, Jessie. Hi, everyone. It's good to be on again. Like Jessie mentioned, I was on a couple months ago to provide an overview of this program. And so today I want to provide just some background information in case folks weren't on the last call that I was on, and then also share some feedback and insights that we heard from the participants that were in our first cohort. So yeah, we'll just jump right in. Next slide, please. So the Montana Infection Control Mentorship Program is a partnership between the Department of Public Health and Human Services, the Montana Public Health Institute, and the Montana APIC chapter. And so really the intent of our program is to match new infection control practitioners in Montana with seasoned infection control practitioners, with the intent of them gaining practical knowledge, helping them identify training and educational opportunities, and also helping build that professional network that's sometimes hard to find when you're feeling like you're working in a silo in a rural part of the state. So we currently have 3 cohorts planned. The first one was this past fall, so September through November. And then our second cohort is kicking off officially next week. So we had our mentor call last week to get everyone oriented and ready to go. And then we'll kick off officially with our full cohort next week, and that group will run through March. And then we have a spring cohort also planned for April through June. And then excitingly, because most of the program is run virtually, we're also planning to have a get together during the Montana APIC Spring Conference in May, just a time to have some in-person live training and also meet folks face-to-face. Next slide, please. So the flyer on the right side, this was our recruitment flyer for this past fall, which provides a little bit of background information on what the intent of the mentorship program is. But then really at the heart of our program, we're basing our materials off of a lot of APIC resources. So the roadmap for the novice infection preventionist really helped outline kind of what our 12 weeks look like. And so part of that includes one-on-one meetings with the mentor and mentee. And then we also do monthly cohort calls, which feature a guest speaker or some sort of training topic. We also have time to do report outs from the different groups so that folks can hear, what are others working on or thinking about. We've also built in in-person site visits. So mentors and mentees have an opportunity to travel to a different site just to kind of see how things are working, in a different facility. And then, like I mentioned, sponsorship to the APIC conference in the spring so that folks can get together and meet face-to-face. So we also have an evaluation survey that we do. Well, we did the first one this past cohort, and then we'll do an evaluation at the end of the cohort, the winter cohort and then the spring cohort, just to help us identify, things that went well, and then also opportunities for improvement or challenges. Next slide. So I wanted to just provide some screenshots of resources that we've developed. So like I said, the roadmap for the novice infection preventionist, that really kind of, outlines the key skills and abilities. So that helps, new ICPs identify what areas to focus on or goals that they want to work towards. And then APIC also has a competency self-assessment activity. And so we've translated that assessment into a survey monkey format that participants, the mentees specifically, complete prior to participating in the program and then at the end of the program as well. So we can kind of see, you know, which areas did they report gaining knowledge or what areas might still be, you know, an opportunity to do some additional training. And then the two documents on the left, or sorry, on the right, are the tools that we've put together to help mentors, you know, kind of facilitate their conversations with mentees. So the first one is a work plan template. And so based on the roadmap and the self-competency assessment, mentors meet with their mentees to kind of develop, you know, what are the 3 goals that you want to work on over the course of this program? What's our meeting frequency? You know, just kind of setting, you know, establishing what the program is going to look like for the mentor and mentee. And then the tiny little picture on the bottom, we're trying to make it as easy as possible. We know that mentors have full-time jobs and lots of responsibilities. And so we really want to make it as easy as possible for them to participate in this mentorship program. So they receive a toolkit prior to the start of the program, which really outlines, you know, here's the 12 weeks, here are the things that you can expect, where to go for resources, and all of that, you know, good background information to make it as easy as possible. Next slide. So then, like I said, all of our materials are based off of, you know, the APIC core competencies with the intention of, you know, if the mentees don't already have CIC credentialing, our program can kind of help them take steps to pursue that credentialing if they're interested. And so these domains are really the basis for our pre and post assessment. And the next slide will be, you know, we had a pretty small cohort our first go around, and so I can't, you know, make any, you know, I don't have a ton of data to go off of to say that we increased the knowledge by X percentage, but I wanted to share a couple of the slides that show, you know, even though we had a small sample size, we are making positive improvements in terms of folks' knowledge. So the next slide, this is 2 areas that we saw the most notable improvements. So same as the last slide, surveillance and epidemiologic investigation, and cleaning, sterilization, and disinfection. And then there's 2 graphs, one for each of the a subcategory within those domains. So the pre-assessment on the top, you can see, you know, folks were kind of, you know, some knowledge, but not a lot, kind of unfamiliar. And then the blue bar, you know, that indicates, you know, feeling like they have a pretty good grasp of the information. So it's kind of, you know, small sample numbers, and the graphs are, I don't know, a little bit hard to interpret. But the blue bar that we see for the post assessment is helping us know that we're moving in the right direction, and that by participating in the mentorship program, folks do feel like they're gaining important knowledge that they can then use in their facility. Next slide. And then this information is based on the evaluation survey. And so a couple of really exciting successes and opportunities for improvement that came out of this. We heard that pairing mentors and mentees based on the type of facility was really helpful. So folks from similar facilities could really learn from each other, and that just enhanced the learning experience. We also heard that the site visit was super helpful, and actually going on site to see how things are working and implemented was really enriching for the program. And then lastly, the mentors and mentees felt like they could really make meaningful progress towards the mentee goals in the 12-week time period, which 12 weeks doesn't seem like a lot, but it was nice to hear that, you know, I think most groups established about 3 goals and felt like they could make really good progress on at least 2 of those goals during the 12 weeks. In terms of opportunities for improvement, the one thing that we heard was that distance between facilities was sometimes a barrier for the site visit. So some of our pairings had folks literally on opposite sides of the state, which unfortunately, you know, created a barrier for the site visit. Another point that I didn't put on here is the EHR system too. And so I think similar to the type of facilities, folks that had a similar EHR system found that they could really, learn some tips and tricks from each other, whereas folks operating on different systems, just didn't have the same context. So exciting stuff though. And then I think my last slide. So like I said, our winter cohort is currently in progress, but we do have a spring cohort planned. And so this group will take place April through June. And if you're interested, feel free to reach out. I think the last time I presented, a couple of folks emailed me afterwards. So if you're interested in participating either as a mentee or a mentor, please feel free to email me, and we'll get you set up for the spring. We do have some incentives for our mentors. So even if you're on the fence, hopefully we can sway you with some of the incentives that we have set up. So I think my last slide is just some resources. So unless there's any questions, I think that's all I had. Oh, and yeah, I'm seeing some questions in the chat about which states this is available to. This is unfortunately for Montana facilities only. Yep, and there's just some resources.
Stephanie, I know last time you spoke about this project, you said if other states were interested in developing a similar program, they could reach out. Is that still an option?
Yeah, absolutely. If I know Erica, who's our counterpart at DPHHS, is on the call today too, but I don't see why we couldn't, share any of the materials we've created. A lot of the things, like I've said, we've put together from APIC resources. So if other states out there are just curious about what this looks like in terms of facilitating the program and putting things together, I'd be happy to chat with those folks too.
And Stephanie, this is Erica. Hey, y'all. So in Montana, this is a federally funded program through CDC. So we wrote, as the HAI program here in Montana, we wrote for grant funding to support this project. So if this is something you're interested in your state, I would highly recommend reaching out to your HAI program coordinator. Every state has one. And just telling them, this is a need. And then they can put it in their grant activities. FYI, we're entering grant writing season, so it might be a good time to tap into your HAI program coordinator. In March, we'll start writing our next grant for our budget period. So that's kind of how it came to be here in Montana, is I just had my IPs coming up to me and saying, hey, we'd really love this, make this happen. And so that's what I would encourage any other states to do as well.
Thank you, Erica. The timing is perfect. So thanks for sharing that message forward.
Great.
Thanks, Stephanie.
Yeah, thank you. Thanks, everyone.
All right. So our next presenter is our very own Lori Chikoyak, and she will be visiting with us today about RSV in the adult population. Lori, the floor is yours.
Thank you so much, and it's great to be with you all today. So we wanted to talk a little bit about RSV. Go ahead and go to the next slide, please. And we're going to be addressing the fact that RSV is not just in the pediatric population. So, but just a little background on RSV first. As we know, it can cause things like a runny nose, sore throat, cough, headache. In small children, we see all of that congestion and boogers, as we like to call them sometimes, coming out. It's spread by respiratory droplets. That's important as we talk a little more about adults. It can spread directly, if you get a cough or a sneeze and then go directly into your eyes, nose, and mouth, or indirectly via surfaces. And that's also important to remember because RSV can live for hours on hard surfaces. So if you get some of the virus on that, it will last for quite a while. RSV tends to have seasonal patterns. It usually is in the winter months. For myself, I live in Alaska, and I know while we say usually on purpose because we do tend to have some unusual trends occasionally, but it does mostly manifest in the winter months. There's currently no vaccine or treatment for RSV, and I'm going to address that on another slide later on. And for most people, the disease usually lasts 1 or 2 weeks, and most people get better, even little kiddos, in like 3 to 8 days. So that's a little bit of background on RSV. Next slide, please. So let's talk just briefly about peds. Most of our focus, I know, is with adults, but we know RSV more in that pediatric population, right? So we know for our babies and our young children, they are at highest risk for RSV, and especially those who are preemies, those who have underlying diseases or compromised immune systems. They're the most likely to be hospitalized and do poorly when they have RSV. Bronchiolitis is the biggest disease we see when kids get RSV. That's just that inflammation of the bronchioles. And of course, our infants, one of the reasons they're at biggest risk, and we've learned this over time with our research, is that they have such tiny airways, and RSV causes such congestion that it's really hard for them to clear that. So if you've heard that phrase before, you just got to clear the snot, you got to clear the snot. Sometimes that is the best supportive care you can give. Okay, let's go ahead to the next slide, please. So what's the risk to older adults? Is RSV really a risk? Well, it is actually. Our older adults are at greater risk of severe disease, especially those, just like the young ones, that may have underlying chronic health conditions or compromised immune systems. And probably a little factoid we don't think about often, but 60 to 100,000 people, elderly people each year, get RSV and are in the hospital with it. So that's quite a large number. And sadly, up to 10% of those people will die. So we know it can cause severe disease. It can cause death in our older population. What we see with RSV in older adults are diseases like pneumonia and other severe illnesses. So if someone has heart failure or COPD, we may see effects from that. So we may see some cardiac effects or other respiratory effects. This is important to address when we think about how we care for our elderly. Next slide, please. So how do we prevent RSV and how do we treat it? So prevention, I love that old saying, prevention, 1 ounce of prevention is worth a pound of cure. And as an infection preventionist, I live by the phrase hand hygiene is critical. It is so true. We all need to remember to do appropriate hand hygiene. Stay away from people that are sick. And especially with RSV, which spreads, as you remember, by direct and indirect contact. Don't kiss those who are sick. Don't get in close contact. This is something I know I struggle with, and I've been an infection preventionist for like going on 2 decades, right? What about that temptation to touch your face? Don't touch your face. We have so many germs, and then it gets on our hands, and then we go spread it to someone else. So do effective hand hygiene. Keep your hands away from areas where we might spread diseases to. So we're talking about RSV here, of course. It's very important that we think about that. Cleaning is very important. So as we're in our homes where we might have an elder, or we're in our long-term care facilities or other facilities that may house our elderly population, we need to be sure we're cleaning and disinfecting those high-touch surfaces really well. So I know I shared before that the virus can live for several hours on surfaces. So, if you've got a group setting and you have people who may be sitting around and watching TV and sharing a remote, for instance, if you've got one person with RSV and they've touched their face and then they touch the remote and the remote goes to the next person and the next person and the next person, you just passed RSV most likely to all of those other people. So remembering those high touch surfaces is critical. Door handles, sink handles, TV remotes, arms of chairs, all those kind of things. So think about that and be sure that those are cleaned and disinfected effectively using an EPA registered disinfectant. So In the long-term care setting, we need to place a resident who may have RSV on droplet precautions. So droplet includes contact, so remember that. But droplet would mean, of course, we need to be sure that we're wearing at least a face mask when we go in and work with them, in addition to our gown and gloves. So, and they should be on that for the duration of the illness. So I mentioned before that there's currently no vaccine or medication to prevent or to cure RSV. There is a vaccine on the horizon. There are studies being done. They're getting close to phase 3 in the trials, which means it's getting close, which really excites me. While I'm more familiar with RSV in infants, I can remember the days almost 20 years ago, literally having 16 babies with RSV in an inpatient unit. And it's no fun. And we'd love to be able to prevent it with a vaccine, but it has taken a long time to get an effective one going. You may have heard of, and I'll butcher the name, so I'll just use the brand name of Syncytial. So you may have heard of that. It is effective for people who may have underlying health conditions to help decrease the severity of RSV. It is not so much a preventative medication that is given, IM. So supportive care is really important. So that congestion may affect breathing, it may affect how they're eating. So we may get people who are dehydrated. So offering fluids is important. Keeping the congestion cleared is really, really important as well. Next slide, please. And here's a look at the CDC has a section, of course, for RSV rates. The link is below, as you'll see. And I just wanted to point out something interesting. We've heard about this trifecta going on, the COVID, the flu, and RSV, and it's so true. So this graph is specific to RSV, and I thought I'd point out because it's really hard to see it in the slide. I really apologize for that. We tried to improve it, and it's scrunched even on the CDC site. But this really looks at about the last 2 years and the pattern of RSV. And we can see a couple of years ago when we were at such the height of the pandemic in the winter of 21 on the left, where you just hardly see a lot. It started coming back over last year, right? 21 into 22. You can see the rise there. Current season and how much higher. Thank you for the toggle there. At the very right, you can see just how much higher this year the RSV numbers are than they were last year. And if we took this back over a decade's worth of time, we would certainly see the same kind of thing. This year, there has just been a lot of RSV. And I believe that is the last slide. Just a really brief look at RSV. It's so, it's an important thing to think about. The symptoms can be similar to other things, right? So it's hard to tease that out sometimes. If you're in a setting where you have the opportunity to do multiplex testing, where you can, do a test that may test for flu, RSV, and COVID, that's really amazing. And be sure that you take advantage of that if you can, because it may help tease out what disease you're facing. Be sure to remember all those good practices. So hand hygiene, cleaning, prevention. So if you do have to put someone on droplet precautions and they're in a room, let's say with someone else, if you can separate them, great. If it's just not possible, be sure to keep that spatial distance, because it is droplet spread. Those droplets can go 3 to 6 feet. So be sure that you maintain distance between them and another person that may be in the room. And for us as caregivers, being sure that we wear all the appropriate personal protective equipment. So stay safe and healthy. My motto is always, we want to keep our residents, our patients, and our staff safe and healthy. So please remember that as you're out there working, and thank you for all you do, and thanks for the chance to share. And we'll leave you with a few resources for RSV as well.
Thank you, Lori. I appreciate it.
To you, Jessie.
Thank you very much. And
Welcome.
as always, we'll send these resources out with next week's presentation reminder, and they'll also be accessible on our website alongside the recording for today's presentation. Does anyone have any questions?
I do, because I know Erica's on the call, so I want to ask
Okay.
a question. So we are currently in outbreak with RSV and influenza and COVID. One of my questions would be, so RSV, you said to keep them on droplet precautions for the duration of the illness. So when you talk duration of the illness, are you talking up to 2 weeks, 8 days? Because, you know, COVID is specific, and then we look at, are they 50% less in symptoms? Are they receiving fever reducing medications? Are they receiving Tylenol in the last 24 hours to really see if we can take them off? So when we're looking at RSV, how are we looking at that? Because duration of illness, if somebody has a cough, one of the staff members can say to me, well, they're still coughing. Well, they could cough for 2 months.
Yeah, and that is a really, really good point. So you mentioned the medication. That's always important to address. You'd want someone to be at least 24 hours off of a fever, reducing kind of medication to make sure that we're not masking any symptoms. So I definitely agree that that's worth watching. And then as well, that duration of illness, yeah, you're not going to stretch it 2 weeks. 2 weeks is kind of the outset. That 3 to 8 day time frame is completely fine. By the time you find out someone has RSV, they're probably a few days into it anyway. So you need to count back to when symptoms started, and then go from there.
Okay, and then my other question is, you talked about, so I do get this question, well, we only have to wear a face mask, and I'm saying, no, you have to wear an N95, and you have to wear eye protection if you're doing direct patient care. So,
yes. Yeah, eye protection is really important. The mucous membranes, so that's why we talk about the eyes, nose, and mouth. The next step from the mucous membrane is your bloodstream. We don't have a skin layer per se protecting those surfaces. And so it's very easy for something like a virus or a bacteria to get through. So it's really critical that we protect those areas. So yes, thank you for bringing up the eye protection as well. So you'd always want to wear at least a face mask, wear your eye protection, wear a gown and gloves as well. So you're not getting it on your, your scrubs and things to transmit. So yeah, very, very important. People tend to not want to wear eye protection. That's what I find. and we forget it is an important area that we can get droplets in and thus spread. And if your staff are out, you're going to have trouble caring for your patients or residents. So do remember that.
okay. Those were the only 2 things, because I know I'm going to get questions about, well, their illness is not over, and then I'm going to have, then I'll just explain to them what we look at, because I don't want to keep anybody on 2 weeks if they don't need to be on 2 weeks. So,
Erica, did you have anything to add for Lisa? But Erica's still on.
Yeah. So I'm not the RSV SME, but what we usually say for these individuals is we want to see an improvement in signs and symptoms, very similar to COVID, right? We also want to be fever-free without the use of fever-reducing medication. So if you're still giving them Tylenol and ibuprofen, we want to look at that. And then we'd also look, are they immunocompromised? What's their immunocompromised status? What makes them immunocompromised? And may they, are they an individual who may be shedding virus a little bit longer that we need to be a little bit more conscious about. And then there's a wonderful sign from CDC on transmission-based precautions. It's green, it says droplet precautions, and it tells you exactly what you need to wear, which includes eye protection and a face mask. So I'm a super visual person, so I love that backup of, hey, you know what, here's what the droplet precaution sign says, and it shows you exactly what PPE to wear. So I completely agree with Lori.
Thank you both. Thanks for the question, Lisa. Very timely, unfortunately, and I'm sorry that that's what you're dealing with right now. Goodness. Well, as always, if anyone comes up with any questions, feel free to reach out to us. If you need any assistance, let me know. And same place, same time next week, next Wednesday. And we will share these slides forward. And Erica just dropped that link to the droplet sign in the chat box, Lisa, if you want to snag it. And if you guys have time, feel free to fill out the survey that's also in chat. Again, reach out if there's anything we can do, and we appreciate all of you. Take care. Thank you.